Hello, good evening, everyone. My name is Mandeep Ferg, and I want to welcome everyone to the NYU Langone Orthopedic webinar, Current Concepts and Treatment of Rotator Cuff Tears. We have an all-star lineup today. We have speakers including myself, Dr. Andrew Rokito, Dr. Young Kwan, Dr. Laith Jezravi, Dr. Joseph Zuckerman. So the format and the agenda for today is we're going to have a series of talks by each one of us, and then we will have a case presentation at the end of the talk. I will get started with the first talk. The topic of my talk today is advances in biologic treatment of rotator cuff tears. These are my disclosures. More than 250,000 rotator cuff repairs are performed in the US every year. We have made a significant progress in the mechanical fixation of rotator cuff tears, but there are limited options for improving biology. Majority of small tears heal after repair, but healing rates in large tears is variable. Failed cuff repair continues to be a major source of morbidity and loss of shoulder function, especially in large tears. Rotator cuff failure can be a mechanical one as a result of structural failure of tendon fixation to the bone. This can happen at the tendon suture interface, largely because of poor quality tissue, or it can be at bone anchor interface because of an anchor pullout in an osteoporotic bone. Factors like pseudoparalysis, early aggressive rehabilitation, and noncompliance in the early post-op phase can predispose to this mechanical failure. Biological failure occurs largely because of poor healing response at the tendon-bone interface. It's largely because of compromised tendon health, which is demonstrated by fatty atrophy or infiltration on an MRI, a tendon tissue loss, and in presence of chronic degenerative tendon tears. Certain patient factors also predispose to biologic failure, like increased physiologic age, smoking, and diabetes. There is increased interest in application of biologic strategies to enhance tendon-to-bone repair and rotator cuff repairs. We need to understand the natural healing mechanism of rotator cuff in response to injury and understand the mechanisms of repair and key players involved in healing and regeneration of rotator cuff tendons in order to utilize this information to our benefit. Tendon healing goes through a series of overlapping phases, which includes the inflammatory phase, the reparative proliferative phase, the remodeling, and the maturation phase. Despite our best attempts, we have not been able to reproduce the structural organization of a tendon enthesis after our cuff repairs. Majority of the time, it is a fibrous scar, which is formed between the repaired tendon and the underlying bone. We all know that any kind of a tissue regeneration requires 4 critical factors, which includes the progenitor cells, the growth factors, scaffold, and good blood supply. Based on this principle, we have biologic strategies to augment rotator cuff repair, largely growth factors, cellular therapies, and scaffold augmentation. For this talk, I'm going to be focusing more on the growth factors and cellular therapies and their role in augmenting cuff repair in 2023. Numerous growth factors participate during different phases of tendon healing as shown in the previous slide. These growth factors and cytokines affect migration of not only inflammatory cells in the initial phase, but also progenitor cells, where they induce proliferation and differentiation of these cells at the repair site into mature cells. We have not identified a single growth factor that predominates the healing process. We have tried growth factor cocktails in preclinical studies, but they are not effective because they are missing the temporal and counter-regulatory control that is seen during normal reparative process. Platelet-rich plasma, as we all are very much aware of, is an autologous biologic product derived from peripheral blood and contains concentrated platelets, which are a rich source of cytokines and growth factors. Majority of cytokines that are involved in rotator cuff healing are also found in high concentrations in PRP, especially the TGF and the basic fibroblast growth factor. The role of PRP in rotator cuff repair has been investigated extensively, both in preclinical studies and clinical trials. So does PRP work for rotator cuff repair? These are some of the level 1 randomized controlled studies that have been published that unanimously demonstrate improved re-tear rates with the application of PRP, but the clinical improvement in VAS scores and outcome scores is short-term, and there's no significant difference in final outcome scores. Then there are some studies which are again randomized controlled trials shown on this slide, which do not show any significant benefit or impact of PRP on cuff repair. At the most, they show some short-term improvement in pain and outcome scores, but no final difference between the PRP group and the control group once healing has occurred. This is a recent meta-analysis that was done of all the randomized controlled trials for PRP, and it again demonstrates that there is improvement in the re-tear rate, but there is not much difference in the clinical outcomes eventually. Now, overall interpretation of these studies is difficult because of lack of standardization of PRP preparation. Leukocyte poor versus leukocyte rich. There is some evidence that leukocyte poor is beneficial for rotator cuff for augmentation of healing. Concentration of platelets, fibrin content, use of anticoagulation are all the factors that are known to induce some sort of disparity between different studies when evaluating them. There still continues to be an ongoing debate about the delivery method, and we know that cost effectiveness has not been established. And especially as an outpatient procedure, it's still not covered by insurance. Cell-based therapy include use of cellular agents that participate in tendon repair via autocrine or paracrine pathways. Both embryonic stem cells and adult progenitor cells are available for cell-based therapies, but in tendon repair, only adult connective tissue progenitors are approved. Largely, cells derived from bone marrow, adipose tissue, and peripheral blood have been tested. They can be used directly after a harvest in which they are concentrated, or after an in vitro expansion and then implanting them after several days to weeks in order to amplify their concentration. Bone marrow stimulation or crimson duvet technique involves multiple cortical perforations in tuberosities using either a punch hole or a drill at the time of the repair. This is an inexpensive strategy to stimulate migration of bone marrow progenitor cells to the site of repair and tuberosity. Several studies have demonstrated the efficacy of this technique. A recent meta-analysis of randomized controlled trials and retrospective cohort study demonstrated reduced re-tear rates, but no significant difference in functional outcomes and VAS scores in patients who underwent the bone marrow stimulation at the time of surgery compared to controls. The bone marrow aspirate concentrate is autologous bone marrow, which is concentrated to enrich the progenitor cell population in bone marrow prior to application at the rotator cuff repair site. Now, this concentrated bone marrow can be used with or without a scaffold. There's enough basic science evidence to demonstrate that bone marrow concentrate has higher number of progenitor cells and higher concentration of growth factors, therefore demonstrating a biologic potential of this product. Harnagu et al. Demonstrated the application of mesenchymal stem cells that were concentrated bone marrow-derived mesenchymal stem cells that were used at the time of arthroscopic rotator cuff repair. They had 45 patients in the treatment group and 45 in the match control. Using ultrasound and MRI, they demonstrated significant improvement in rotator cuff healing rates both at 6 months and 10 years with local application of bone marrow-derived mesenchymal stem cells. Similarly, a recent randomized controlled trial by Cole et al. Demonstrated that patients that received concentrated bone marrow cells from iliac crest at time of rotator cuff had a significantly reduced re-tear rate compared to the control. There was no difference in the outcome score or clinical failure, which they defined it as a decreased 1 or 2 year ASCS score compared to the preoperative baseline, need for revision rotator cuff repair, or a conversion to reverse total shoulder. Adipose-derived stem cells are another source of mesenchymal stem cell or progenitor cells that can be used for augmenting repair. Compared to bone marrow stem cells, they're easy to obtain. Just like them, they're pluripotential and stimulate migration of tenocytes. The tissue can be obtained via liposuction as an outpatient procedure. Typically, these cells are expanded in vitro and then transplanted a few weeks later. Their recent studies have shown some value in reducing the re-tear rate, although the final outcomes are no different. This is a study by Kim et al. In which 35 rotator cuff tears were treated with or without injection of adipose-derived mesenchymal stem cells using a fibrin glue. They did not find any significant difference in the constant score or the UCLA score at final follow-up of average 28 months, but they did find a significant difference in re-tear rate between the treatment group and the control group. Tendon-derived progenitor cells, the rotator cuff itself is a valuable source for these connective tissue progenitors. These cells have potential to differentiate into other cells of mesenchymal origin in presence of specific growth factors and transcriptional signals, although there are limited clinical studies to demonstrate their efficacies, but down the road, this will be another strategy in the pipeline. Now, there are some challenges to using these tendon-derived progenitor cells harvested from rotator cuff tissue at the time of surgery, because there are no identifiable growth factors that can direct their healing. By themselves, their population may be very small to be directly implanted at the time of repair. They are very low number in the native tissue, so harvest from the native tissue may be limited. And since majority of cuff tears are degenerative, the cellular pool of these progenitor cells is further compromised and of low yield. Now, if you look at all the studies that I have delineated so far using different biologic treatments, they all had a common theme of showing some difference in the re-tear rate, which was significant in majority of studies, but they did not affect the final outcome. And that is largely because there's a disconnect between the clinical outcomes and structural integrity of rotator cuff. So it becomes really difficult to prove their value, but they have a unanimous theme of showing reduced re-tear with their application. So in conclusion, majority of mechanical failures of rotator cuff occur at the tendon suture interface. It's the biology that we are struggling with. No surgical repair as of yet has been successful in recapitulating the structural organization of rotator cuff enthesis. Use of biologic strategies for enhancing rotator cuff repair is still evolving. Bone marrow stimulation continues to be an inexpensive strategy that has shown efficacy in reducing cuff tear, re-tear rates. Leukocyte-poor PRP, concentrated bone marrow aspirate, adipose-derived stem cells have a potential role in reducing rotator cuff re-tear, especially in mid to large-sized tears, but they need further investigation to standardize their preparations and efficacy in improving outcomes. The indications and cost effectiveness of biologic strategies needs further refinement to justify their use for rotator cuff in future. Thank you very much. After this talk, we are going to go to our next speaker, which is Dr. Andrew Roquito, who's going to be talking about surgical principles of rotator cuff repair.
So I'll need to go to, first slide. Okay. In this presentation, I'll be discussing some of the basic surgical principles that we commonly utilize during rotator cuff repair surgery. This, by no means, is meant to be an all-encompassing talk, but rather a review of what I think are the most important components for a successful outcome. So to begin, it's very important to be familiar with the classic tear pattern shown here on these cadaveric specimens. Understanding the morphology of the tear is extremely important before deciding on a repair construct that is biomechanically suited to withstand the stresses during the healing process. When dealing with partial thickness rotator cuff tears, it's important to assess the degree of tearing and what we commonly refer to as footprint compromise. Typically, for cases in which less than 50% of the footprint is compromised, debridement alone is performed. This is typically the case for partial articulosided tears or POSTA lesions. Bursal-sided tears, as seen here, are usually completed and then repaired to bone, as we normally would for a full-thickness tear. So I'm going to begin with some very basic but important evidence-based assumptions. First, I will submit to you that repairability is not a technical question, as in most cases, even in very large or massive size tears, as seen in the top left over there, we're typically able to perform a repair. The question is, however, whether performing that repair will lead to a satisfactory clinical outcome. Faced with a full thickness rotator cuff tear. The first three really apply predominantly to those large and massive size tears requiring mobilization. When faced with a large or massive size rotator cuff tear that requires mobilization, we typically begin with a juxtaglenoid capsulotomy, and this is done while viewing from the posterior portal and working through an anterior portal, passing a blunt elevator between the superior labrum and the scarred rotator cuff. This is done gently, being careful not to plunge the elevator too far medially so as to avoid injury to the suprascapular nerve. Next, while working in the subacromial space, we begin to mobilize first with a posterior superior release. This is first done with a shaver or an ablation device, and then an elevator releasing the cuff from the scapular spine. Next, we perform an anterior superior release, seen here using first an ablation device, and then a curved blunt elevator passed from posterior to anterior, releasing the coracohumeral ligament and the rotator interval. Following the appropriate releases, we begin our repair. For U and L-shaped tears, this begins with side-to-side suturing or margin convergence. And this is followed by tendon to bone repair with the goal of creating a construct with no time zero gap formation. So to summarize, I do not typically perform interval slides as I think that that is potentially biomechanically disruptive and without much clinical benefit. I do release all of the adhesed cuff as I showed, and if I can't completely close the defect, I'll make sure at least that the subscapularis anteriorly and the infraspinatus tendons posteriorly are secured so that force couples are balanced, which hopefully will lead to a good functional outcome. Preoperative stiffness should ideally be addressed prior to cuff repair with appropriate PT and stretching exercises, but a careful examination under anesthesia is always performed prior to repair in order to confirm that range of motion has been restored in all passive range of motion planes. These procedures can be performed equally well in the beach chair or lateral decubitus positions. I prefer the lateral decubitus position using single suspension traction. However, when mobilizing and repairing the cuff, I do rotate the arm to ensure that I have adequate mobility and I'm not repairing the tissue under tension. For the majority of tears, we typically utilize 4 portals: a standard posterior viewing portal, an anterior working portal, and suture management portal, a lateral portal which we position at the center of the tear, and an accessory portal placed just off the lateral edge of the acromion for anchor placement. Of course, additional portals can be created as needed. A systematic assessment of the glenohumeral joint is performed first. Biceps tendon pathology is addressed as needed. The subscapularis is best visualized by advancing the scope towards the rotator interval and then rotating the camera toward its insertion while performing a posterior lever push. This allows you to look at the subscapularis insertion, the adjacent comet tissue, to ensure that it's intact. If there is a subscapularis tendon tear, we will repair it at this point. The articular surface of the rotator cuff is then assessed for any for degree of tearing, retraction, and tissue quality before moving to the subacromial space. While I don't routinely perform an acromioplasty, a thorough bursectomy is needed for visualization and suture management, being mindful not to extend the resection too far distally so as to avoid injury to the axillary nerve. With the goal of performing a tension-free repair, tendon releases are performed in a systematic fashion, as I just discussed. And once the cuff is adequately mobilized, a full assessment of tear morphology is needed, as this will determine our repair technique. And as I alluded to earlier, it's very important to assess both morphology and mobility through multiple portals so as to give you a complete three-dimensional understanding of what repair construct will work best. Tissue quality and mobility are assessed using graspers and traction sutures. Assessing tear mobility with the shoulder and adduction is important in order to ensure a tension-free repair. Here's a case that looked like a typical crescent-shaped tear when viewed from the posterior portal, but when we reposition the scope into a lateral portal, it's obvious that this was a partial bursal-sided tear that required completion and then repair as we would for a full-thickness tear. The footprint is prepared by removing remaining soft tissue and gentle abrasion. Excessive bone removal, however, needs to be avoided as this may compromise suture anchor fixation. As you just heard, microfractures can be placed to stimulate bone marrow and promote a healing response. For margin convergence, while viewing from the lateral portal, sutures are passed across both tear leaflets, progressing from apex to lateral. We tie sutures through the posterior cannula, and once the margins are secured, suture anchors are used to fix the tendon edge to bone. Anchors are placed at a 45-degree angle. They're placed through an accessory portal just off the lateral aspect of the acromion. And after the anchors are placed, they're tested by pulling up on the sutures to ensure that they're adequately fixed to bone. For double row constructs, medial anchors are placed just adjacent to the articular margin, and lateral row anchors are positioned lateral to the graded tuberosity. It's important not to overcrowd the tuberosity with too many anchors, so we will utilize double and sometimes triple loaded anchors to avoid overcrowding. So there are multiple methods for passing sutures. When using a direct passing device, we prefer to pass sutures while viewing from the posterior portal. And if a shuttling technique is used, we'll typically view from the lateral portal and come in with a shuttling device either through an anterior or posterior portal. In general, suture passage progresses from anterior to posterior, and then tying is progressed from posterior to anterior. In order to minimize suture cut through, 10 to 12 millimeter bites of tissue are usually taken, and depending upon the repair technique and tissue quality, a variety of stitch patterns can be used. Again, it's important to recognize that the primary mode of failure is suture cut through, so taking large medial bites of tissue and using ripstop sutures are important to consider, especially when faced with poor tissue quality. So while there are a lot of commercially available knotless devices, it's still important to become proficient at knot tying, as undoubtedly you'll be faced with tears where tying knots is required. So in summary, the basic surgical principles of rotator cuff repair involve first and foremost patient selection, recognizing the various tear patterns by viewing through multiple portals, systematically mobilizing and releasing tendons, and then performing a biomechanically sound, secure tendon-to-bone repair without gap formation. Thank you.
That was an excellent talk on surgical principles. Thank you, Dr. Rotator. Our next speaker is Dr. Young Kwon, who's going to talk about tendon transfer and their indications and outcomes with rotator cuff repair.
All right, good evening, everybody. So my task tonight is to talk about the role of tendon transfers in patients with massive cuff tears. So I don't have any relevant disclosures. This is not advancing. Okay, guys, I don't know. I'm having a little issue advancing. There it goes. Okay, I guess there's a bit of a lag. Anyway, so I have no relevant disclosures. As Dr. Rotator just mentioned, sorry, it's not advancing when I'm pressing. So
go ahead and click on the slides, please.
Okay. There it goes. Okay, so one of the first things I like to talk to and mention to everybody is the fact that before you consider a tendon transfer, you really want to just make sure that patients really need it. As Dr. Rotator mentioned, a well-done repair, patients will do much better. And a repair is certainly preferential to any of the salvage options we're going to talk about, whether it be tendon transfers or superior capsular reconstruction or balloon arthroplasty. So we should really make sure that the rotator cuff is really truly not repairable before we consider any of these salvage options. And in fact, there's some data to suggest that even a partial repair may be preferable to patients undergoing a salvage procedure itself. So if you really are going to consider doing tendon transfer, well, who are the appropriate patients? Unfortunately, this is a topic that we still don't have a lot of clarity about, and we're still trying to investigate in detail. So obviously, we're trying to treat patients whose rotator cuff is massive and that is not repairable. And basically, we're trying to address the defect created by the rotator cuff tear by augmenting the shoulder with a tendon from different areas that surround the shoulder. Generally, we're talking about patients that are physiologically young. So basically, patients who are 50 or younger if possible. Essentially, we're trying to train the muscle to do something it hadn't done before. So for that, you need a little plasticity in order to adapt the muscle. Basically, other than the rotator cuff tear, you want the shoulder to be in pretty good condition. So minimal arthritis, the deltoid is intact. The humeral head ideally should be centered. And basically, majority of the tendon transfer data would suggest that the patients do better if they're at least able to initiate their active elevation, meaning they could at least raise their arm to about 50 to 70 degrees. If so, tendon transfers could really, really help. Patients who are essentially pseudo-paralytic, they don't do very well with tendon transfers. Once again, these are tendon transfers are performed primarily for patients whose primary complaint is weakness. Obviously, many patients do complain of pain, but if their primary complaint of pain, including pain at rest, these are not patients that may do well with tendon transfers. So these are some of the tendon transfers that we're going to be talking about. We're going to talk about specifically on those type of transfers that are in red. So if a patient has a anterior defect, either the subscapularis with or probably a small portion of the anterior supraspinatus, you could possibly transfer pectoralis. We don't take the entire pectoralis. Usually you're just taking the sternal head of the pectoralis, hence the split pectoralis major transfer. If the rotator cuff tear is in the top or in the back of the shoulder, so supraspinatus, infraspinatus with possible involvement of teres, then we're taking a muscle from the back, so typically the latissimus or the lower trapezius. The lower trapezius transfer has become a lot more popular, so we're going to be talking about that probably in a little more detail. If a patient has a global loss of a rotator cuff, certainly in the past, we used to do double or multiple tendon transfer, so a pectoralis combined with a latissimus. But generally, if these patients are generally fairly pseudoparalytic, and multiple transfer would be very, very morbid, especially given the fact that the reverse shoulder arthroplasty is available. I think the multiple tendon transfer is very, very rarely performed. All right, so let's talk about the first one. So we're talking about the pectoralis major tendon transfer. Generally, once again, these are patients with irreparable cuff in the front, so subscapularis, or just the anterior portion of the supraspinatus. The arthritis should be minimal, and they should also have minimal pain at rest. And basically what we're talking about is taking the sternal portion. So remember, the pectoralis has the clavicular head and the sternal head. We're taking the sternal head, which is actually deeper and inserts more superficial on the humerus. We're going to take that portion, isolate it, and pass it to the lesser tuberosity. And this is kind of what the pictures look like. The diagrams always look great, but in reality, this is kind of what it looks like. It kind of looks like a big jumble mess, and it's unfortunately a fairly morbid procedure. The tendon can be transferred above or deep to the coracoid process and the conjoint tendon. In theory, you should transfer the tendon deep to the conjoint because it is more physiologically similar to the line of action of the subscapularis. However, this is a lot more difficult surgery with more dissection, and there's a risk of neurologic injury to the musculocutaneous nerve. Part of it isn't just the tendon itself or the surgical exposure, it's probably also the muscle bulk. The pectoralis major, as many of you know, is fairly short. So by the time you isolate it and transfer it to the lesser tuberosity, majority of the tissue that's underneath the conjoint is actually the muscle bulk. So if the patient has a big muscle, then you're going to displace the conjoint tendon and possibly causing more traction injury to the musculocutaneous nerve. How do these patients do? These are sort of older literature, but they generally do okay. So satisfaction is reasonable. Confidence score goes to about 70. One of the concerning findings from Lisa Galatz was that despite the transfer, only about 50% had their humeral head that was contained and did not sublux anteriorly. So that was a little bit of concern, but majority of the patients, like I said, seems to do okay. In fact, if you put all the data together, we're talking about 80% success rate. Okay, or 80% satisfaction rate. Now, I personally have a hard time believing that all these patients, or 80% of these patients, are really satisfied. My guess is that we've done just a good job counseling the patient preoperatively about what the expectation should be. None of these patients should expect a normal shoulder, and all of them will have to live with some limitations. What we're trying to do is regain active elevation and better functional use of the arm. So I think patient counseling is very, very important, and this certainly illustrates the fact that we are able to obtain 80% satisfaction with such a morbid surgery. All right, so moving on to the next transfer, which is a latissimus dorsi. which is actually a big muscle in the back of the shoulder. And normally it internally rotates the shoulder. But if you take the tendon and put it to the greater tuberosity, it can potentially act as a restraint against internal rotation and provide better balance. So once again, these are for patients whose posterior superior rotator cuff is torn and not repairable with intact subscapularis. Generally, once again, patients who are physiologically a little bit younger and able to retrain their muscles and with center humeral head. They also should be able to at least initiate their active elevation to about 70 to 80 degrees. So if they're truly supraparalytic, left dorsal transfer, or really any transfer probably won't work very well. So this would be an ideal patient. As you can see here, he could actually elevate to about 100 or 110 degrees already on his own. And he's got good subscap. He's got good, you can see that he's got negative belly press and negative liftoff. So this would be an ideal patient whose rotator cuff is clearly torn. These are the pictures that I borrowed from Dr. Ainati. And once again, it's a fairly morbid procedure with lots of dissection. To orient the pictures, we are looking at the back of the shoulder with the arm on the superior portion. To the right would be the foot, and to the left would be the head. So you're looking at back of the shoulder. And this is what the diagram would look like. And you can see here, this is a latissimus, and it's actually fairly broad tendon. When you do the dissection and harvesting the tendon from the bone, you have to make sure that you look being very careful on the bottom, because the radial nerve and the brachial artery is right there. Radial nerve is very, very prone to injury, especially to neuropraxia. So during this phase, not only do you have to actually see the tendon directly, you almost want to make sure where the nerve is, because it's not only the harvest, but where you place the retractors that can also often cause the actual injury. Once you have the tendon, like I said, the tendon is fairly broad and actually pretty long. Once you have that, then obviously you control it and pass it to the shoulder, generally requiring a second incision in the shoulder. That's what is done here. And then once you have it transferred to the shoulder, then you're going to fix it to as many points as possible. So obviously to the greater tuberosity, you could use suture anchors, or you could just use sutures through the bone. If medially there's any remaining rotator cuff, you're going to fix it with sutures. And if you can get sufficient length or excursion, you could actually also take the anterior-most portion of the transfer to the subscapularis tendon as well. And this is what sort of would look like. Once again, the data would suggest that patients do reasonably well. So constant score going to about 70, which would be a good result, not an excellent result, but certainly a good result. Forward flexion going to anywhere from 120 to 150, depending on where you started. As you noticed on the last paper, if your forward flexion was very low, meaning you can't initiate the forward flexion on your own, then it's difficult to regain a good field of motion. Now we're going to then move on to lower trapezius. Lower trapezius has gotten a lot more attention recently because it's certainly increased in popularity. Part of it is because it is definitely less morbid. A lot of the portion of the tendon transfer surgery is done arthroscopically, so you could utilize small incisions, and you don't have to have a huge dissection. So this is a lot easier for patients to recover from. The indication for this transfer is the same as the latissimus. So basically patients with posterior superior rotator cuff tears with minimal arthritis and intact subscapularis. Once again, patients who are able to initiate their initial activation are those that's going to do well. So this is a video of my patient that I've done. I believe this was at the VA. So I set up the patient just like you do for any shoulder arthroscopy in a captain's chair. You just have to expose the medial part of the scapula. The actual incision is the posterior medial corner or the inferior border of the medial scapula. There's a fat pad that's usually there. Once you get the fat pad out of the way, the first tendon you see that's actually attached to the inferior border of the scapula is the latissimus. So it's very easy to identify and grab. Once you secure that with sutures, then you want to get maximal excursion. Despite all the releases, this tendon does not transfer very far. So there's no way to get this tendon to transfer all the way to the humerus. So you're going to need a graft. Generally, the Achilles tendon is used. Once the trapezius is identified, then you go into the shoulder. At this part, we're going to do this arthroscopically. Obviously, we confirm that the rotator cuff is not repairable. And you go in with various arthroscopic instruments and essentially identify the path where you're going to pass the graft. So you take the Achilles tendon allograft, you pass it from the medial incision into the shoulder, and you can visualize this arthroscopically. You can see the sutures coming in that's holding the graft. the graft is then passed underneath the deltoid right into the shoulder joint. And you can see the tendon coming in the upper left corner. Once the graft is passed, you want to then fix it to the greater tuberosity. Basamal who probably has more experience with this than most of us, has always told me that he felt comfortable just fixing this with 2 anchors. I personally think that may be a little too little. I generally use about 4 anchors. The Achilles tendon is also very thick at this point. So when you put the tendon transfer, sometimes the visualization is a little more difficult and you have to use accessory portals and possibly retractors to get the tendon out of the way while you're inserting the anchors. So you can see the tendon right there. I'm trying to move it in and out of the way. And I feel like I have a reasonably secure. Like I said, this takes a little practice, but once with a little practice, this is really not that difficult portion. After the tendon is passed, you take the tendon and then you tension it and fix it to the trapezius tendon itself. What position do you secure this while you're fixing the tendon together? You're sewing the tendon together. No one really knows. I think generally you want to keep the arm in at least neutral rotation, if not in a little external rotation. I've had some surgeons describe that he externally rotates to 45 degrees. That seems a little excessive to me. I generally hold the arm in about 20 to 30 when I fix this. You trim away all the excessive stuff and close the wound. And what you're going to see here is that clearly this is not nearly as morbid as a latissimus. You can see here the arthroscopic portals, and the incision around the scapula is actually not very big either. So how do these patients do? So Basamal, like I said, probably has the most experience. This is what his initial report from 2016, 33 patients, 32 noting pretty good improvements in pain. He thought that the patients did pretty well, and average elevation to 120, but this included patients who could not elevate their arm at all. So including patients who were pseudo-paralytic. I think since the report, he's then changed his protocol and basically try to include only patients who could at least initiate their active elevation to about 50 to 60 degrees, because the ones who could not do so were the ones who could not raise the arm very well and did poorly. Subsequently, there's been a lot more reports on this. So last year, our Korean colleagues, Bak and all, have reported on multiple tendon transfer patients. They compared the latissimus versus the trapezius. And this would be a similar group of patients because they both have posterior superior cuff tears. Trapezius transfer patients seem to have done better. They have a little better external rotation as well as patient-reported outcome scores. When they compare trapezius versus SCR, so superior capsular reconstruction patients, they also thought that the trapezius transfer patients did a little bit better as well. However, they will admit that the trapezius patients and SCR patients were not identical from the beginning. They had a little bit different indication, different age, etc. Similarly, our Mayo group reported on their experience with trapezius versus SCR. Again, they mentioned that these are not similar patients, so we are unfortunately comparing a little bit of apples and oranges. But at least in that group, they had similar patient-reported outcome scores. Also, although the patients with SCR did a little bit better with terms of elevation and lower VAS. All right. So overall, basically, we're trying with the muscle tendon transfer, we're trying to address the defect in the cuff, whether it be anterior or posterior superior, so that we could restore the force coupling around the shoulder and balance the joint. Some of the earlier surgeries were very morbid with lots of rehabilitation, but generally patients are able to get active elevation back. And so functional use of the arm has increased greatly. Who is the optimal patient for this? We don't know yet, and we're trying to do more studies and examination of that. So you really do have to get the patients involved, and this has to be, patient have to be involved in the decision to proceed with a rotator cuff, either repair or tendon transfer, because obviously those are very, very different in terms of rehab as well as morbidity. Thank you very much.
Thank you, Dr. Kwan. That was an excellent presentation. We're going to switch gears and go to superior capsular reconstruction, subacromial balloon spacer for treatment of irreparable rotator cuff tears. This talk will be presented by Dr. Laith Jezravi.
Thanks, Mandeep. I'm going to talk about superior capsular reconstruction and get a little bit into the balloon for massive irreparable rotator cuff tears. I have nothing relevant in terms of disclosures for this talk. Okay, so we sort of touched base a little on our options for the massive rotator cuff repairs. Certainly, non-op rehab is an option in some of these patients, and there's some data to suggest that this may work. Dr. Riquito spoke about rotator cuff repair. When you can fix it, definitely try to fix it, potentially augment it with a patch if necessary. Dr. Kwan just talked about muscle transfers. I'm going to get into SCR and balloons. And then Dr. Zuckerman's going to get into reverse shoulders and reverse shoulders plus muscle transfers. But I think the key to understand when you're deciding between an SCR balloon and then potentially a reverse, you really got to look at the Hamada classification. And when you start to get above a grade 3 Hamada, then you're getting into real arthritis in the shoulder, and that's when you need to start considering a reverse. Look at this patient. This is courtesy of one of my friends, JT Tokish. You have, he's a 65-year-old farmer. On the left side of his shoulder, he's got a massive rotator cuff tear, no real significant DJD, pretty good motion, grade 0 to 2 Goutallier. So basically he's got good muscle there. There's not much fatty atrophy, and bad tendon. And really, JT's quote is that hope lives in the muscle. And when you have muscle that's there, that looks reasonably well without much muscle atrophy, his left shoulder you can get away with an SCR potentially. As opposed to his right shoulder, and this has been brought up, non-functional, pseudo-paralytic, he's got DJD, he's got fatty atrophy that's pretty significant, a Goutallier, so essentially bad muscle. And, JT's quote is no muscle, no hope. So don't do an SCR in this case, that's a reverse. And I think that's what I want to get into. There's been a lot of hype about an SCR potentially reversing certain cases of pseudoparalysis. And I think that's very challenging, and that's asking a lot of the SCR, and I don't think it works in a lot of those cases. So when you look at a treatment algorithm, and it's often nice to go through treatment algorithms to try to figure out where is the indication, for these. So if you have the massive irreparable rotator cuff tear, you're looking at whether they have DJD or not. And I think that's one significant bucket. And certainly, if they have significant DJD, you're going down a different pathway, which is ending up in a reverse. So that's pretty easy, and Dr. Zuckerman's going to get into that. But what about that group who has no significant DJD? You've got ones that are active and less than 65, and then those that are greater than 65 that are inactive. And if they're inactive, greater than 65, massive irreparable cuff tear, certainly I think you're going down the road of you want to get a reasonable result that's predictable. You're going to do a reverse in that patient. But what about the patient who's active and then has a functional cuff, no real significant pseudoparalysis? And then there's also the group that's non-functional, that's pseudoparalysis, has fatty atrophy of the muscle. What are your options here? And you look at that functional group, you can essentially do anything on them and get a pretty good outcome that's supported in the literature. Whether you use a balloon, whether you even do a biceps tenotomy or an anterior cable reconstruction with the biceps tendon, partial repair, superior capsular reconstruction, as long as they're functional and can get their arm above 90 degrees, you can do any of these things and probably get a good result. The challenge is in that non-functional patient. Now, then you got to decide, what's the Goutallier class? Is it grade 3, 4, 0, 2, where the muscle's alive, or essentially cuff muscle dead in that Goutallier 3, 4? And I think that's where you have to decide. If the muscle's dead, then you're looking at a lower trap transfer, because I don't think an SCR is going to be able to, you can put a patch there, but it's not going to do anything for function. So the lower trap transfer, if they have some ability to initiate their shoulder motion, but still have a pseudoparalysis where they're unable to get their arm above 90, I think that's where the tendon transfers come in. But if the muscle's alive, even though they're non-functional and they can initiate motion, potentially, in this case, as long as you have some good muscle, you could potentially do an SCR. And these are the cases where pseudoparalysis could be essentially reversed in some cases. So again, getting back to basics, if the shoulder is functional but painful, maybe there's a reason for the pain. And I think the French have focused on this, that an isolated biceps tenotomy in certain cases may be acceptable. And in Gilles Walsh's series, there was a less than a 10% conversion to reverse a 10-year follow-up for massive tears and a pretty good constant score. Dr. Kwan presented that with a lower trap transfer is getting close to 70. In this case, just a biceps tenotomy in a functional shoulder, achieving a constant score of 70. So I think that's pretty good. What about superior capsular reconstruction? Well, the initial report came out by Mahata, but I think we forget, Hamada excluded a lot of the significant arthritic patients, but he also harvested a 6 to 8 millimeter thick fascia lata. And I think that's where we're seeing trouble, trying to reproduce his results. And it's challenging. His results of 83.3%, no graft tears at mean 34-month follow-up, that has been consistently followed for sort of his midterm follow-up as well. And range of motion, ASES has improved significantly in his patient cohort. When you look at the dermal grafts here, 3.5 millimeters, the ones that we use in the United States, there's certain advantages, right? You're not harvesting. You're avoiding any of the morbidity associated with that. You can allow faster mobilization of the patients, and it's easier. You're not having to harvest a thicker graft and putting it together. The dermal graft comes already set to go to pass the sutures through. You just have to cut it to size. The results here, and as is everything in orthopedics, the early results, they're going to be good. And you can see here, low revision rate, failure rates were there, but 14%. But I think the key is when you look at and really start critically looking at this with other studies, look at Warner's study. He had 34 patients, 22 failures with the dermal allograft. So I think this is significant. And he gave reasons for the failure, more fatty atrophy, probably some non-functional shoulders in this cohort, and low surgeon volume. But I think what we're beginning to see is that the thickness of the graft, I think, really matters. And some of the newer patches that are coming out, dermal patches, are closer to 5 or 6 millimeters. And when you look at the data, a thick fascial lata autograft, minimum 6 millimeters, again, from Mahata's group, again, much lower tear rate with a larger group series here. And then this is the concept of the SCR. You're trying to create a reverse trampoline effect that prevents this superior migration, or actually limits it so that the shoulder can engage. So you really want to get the lower Hamada score so that the shoulder centered, so that they can engage motion and lift their arm above head. And then what we're really beginning to see with the SCR, that it's really a pain reliever. So when you look at a patient like this is one of my early cases, large retracted supra-infra tear, Goutallier 2, so relatively good muscle function, intact subscap, no pseudoparalysis, but Hamada grade 3, right? Starting to get that high riding humeral head, no significant arthritis yet, maybe on the sort of the edge of an indication for doing an SCR. But in this case, I ended up, doing it. This is one of my earlier cases. So failed prior cuff tear, do a biceps tenotomy. I think that's, key in these cases for pain relief, whether you do a tenodesis or not. I think that's up to you. I think bony preparation is critical. You really want to get, over the glenoid. You got to be careful. Don't go more than 2 centimeters medially. You'll hit the suprascapular nerve. Prepare the bony bed. Get rid of any of the old suture material. Then you're going to put your anchor replacement. This is one of my earlier cases where I use 2 anchors on the glenoid, and these are where I'm tying sutures. These are not the knotless push locks or the knotless anchors with the fiber tacks, which I use now. Again, swivels. We still use the swivels on the medial border right adjacent to the articular surface with the tapes. And then you insert one anteriorly, one posteriorly, and you can insert, depending on the size of the graft, sometimes you'll end up doing 3 of these swivels laterally. Then you're going to size the graft. You're going to measure in between the anchors along the glenoid, and then you're going to measure along the anchors laterally on the humeral head, and then from medial to lateral as well. And this will give you sort of the dimensions of the graft. And then you add several millimeters around the graft in addition, so there's no suture cutout. And this is here just showing the graft sizing and passing. This is, the sutures are passed outside the shoulder. This allows you to then drag the graft into the shoulder. And then now graft fixation. So the graft slid in, and then these are the sutures are then brought out the cannula, and then you start tying these sutures first on the glenoid, and then on the humerus. And then once you have that, then you're going to do some side-to-side fixations. This is the infra and the back, where we suture the graft to the back there. And this was certainly in the initial technique where you did that. Initially, they didn't think that suturing it to the subscap anteriorly was critical, or to the anterior tissue. You know, I think that's very important to prevent superior escape as well, if the patients have a Hamada 3 like this. So you're suturing down the infra and the back. Now you're going to come to the front and start suturing down the patch to the anterior tissue, and to get, you know, sort of this closed and get a tight seal of the patch to the native rotator cuff. And this is sort of the final construct where you're looking to get, you know, patch coverage over the humeral head. So what about the in-balloon spacer? We talked about some of the indications of essentially a functional cuff. So this is a biodegradable balloon implant. It degrades after 3 or 6 months and conforms to the rehabilitation time frame following any repair. And in most cases, you're not doing a repair. The initial studies which compared it was either patch with no repair versus a partial repair, and these are arthroscopically deployed. So when you looked at the InSpace FDA study, randomized controlled trial, single-blinded non-inferiority, InSpace device versus partial rotator cuff repair, 2-year follow-up, MRIs at week 6 and year 1, functional assessment, and adverse events monitored. And essentially, when you looked at this study, both the partial repairs and the InSpace balloons, they all did better in terms of their scores. The InSpace balloon had slightly, better VAS scores, slightly better ASEA scores, and a slightly better constant score. They also had slightly better mean forward elevation, and I think that had to do with the earlier rehabilitation that the patients had, and then also a better WOSI score. However, other randomized, double-blinded studies looked at, again, the balloon as well versus debridement only, not even a repair. So no change. So a very similar postoperative rehabilitation in terms of timing. And they showed in this study, essentially, the results favored the debridement only group. So, and we can get certainly into this in the discussion, what the role is for the balloon exactly, but it certainly has to be a functional shoulder, intact subscap, no arthritis. And I think then, like I said, you can choose any of those other things, balloon, SCR, biceps tenotomy, potentially partial repair. All these could potentially work in this group. So take-home points, Hamada grade is key when you're looking at these patients. Degree of fatty infiltration is also key. But I think the most important thing is that a pseudo-paralytic shoulder with significant fatty infiltration, that's a different animal, that's a different beast, that's getting a reverse. If the shoulder's functional, you can do almost anything and have a good outcome. And again, lastly, beware of pseudoparalysis with muscle atrophy. That needs a reverse. Thank you.
Thank you, Dr. Jazravi. That was an excellent presentation. We're going to move from a shoulder preservation talk now to a shoulder replacement talk. And the next talk is going to be by Dr. Zuckerman on reverse shoulder arthroplasty and rotator cuff tears, indications and outcomes.
Thank you, Dr. Burke. So you heard reverse shoulder arthroplasty mentioned a number of times by the speakers. So I'm going to try and wrap it up and talk about my indications for doing this. My disclosures are relevant because I am a design surgeon for Exactech for a shoulder arthroplasty system. So before reverse shoulders came around, there weren't a whole lot of prosthetic options for massive rotator cuff tears. I mean, basically, you can only take care of patients with a massive cuff tear and arthritis. There had to be rotator cuff arthropathy patients, and the only goal of the surgery was pain relief. Functional improvement was really limited, and basically you did a hemiarthroplasty. In the early days, we didn't have the so-called extended head, so we just did a hemi. If you look at the results of this procedure, right? It is an early article we did over 20 years ago about a hemiarthroplasty with cuff tear arthropathy before reverses came out, and there were modest gains. Although 87% were satisfied, that was in a limited goals category. So these were not great results when you increase the forward elevation from 69 degrees to 86 degrees on average. So clearly not a solution. So when I think about consideration of arthroplasty for the presence of rotator cuff tears, there are three clinical scenarios. One is the massive irreparable rotator cuff tear without arthritis. The rotator cuff deficient shoulder with gluteoarthritis is another category. We're not discussing that here. And of course, cuff tear arthropathy. We're only focusing on number one, absence of arthritis with a massive irreparable tear. In that particular situation, it's characterized by multiple tendon tears. Oftentimes, they've had previous surgery. You see in this particular X-ray significant superior migration, anchors, metal anchors, and other anchors within the head. They have significant functional deficits, and they have little, if any, arthritis. That's basically the scenario. And when you have that situation, right, even in that context, the spectrum of how the patients present is very variable. The variation becomes most evident in the degree of pain they have, the age of the patient, previous surgery, the range of motion, and particularly patient expectations. And that will vary from one patient to another. So I like to consider, two types of patients, patient A versus patient B. And I know that I'm generalizing here, but I'm doing this to make a point. But patient A, the pseudo-paralytic that you've heard so much about, who has severe disabling pain, 70 years old or older, with a sedentary lifestyle, those patients are clearly relatively straightforward to take care of. You're not going to do a superior capsular reconstruction. You're not going to do a balloon. You're not going to do tendon transfers. Those patients are going to get reversed. That's an easy one, all right? However, patient B, the patient who is younger, not necessarily 45, but younger, more active, still has severe disabling pain, but a near full range of motion or a much more functional range of motion. And in this particular patient, absence of arthritis, but an MRI that shows extensive rotator cuff atrophy, irreparable tears, multiple tendon involvement. But for some reason, their range of motion is relatively preserved. I mean, when I say for some reason, I'm being somewhat facetious. I mean, these patients somehow they balance with their accessory musculature to be able to maintain range of motion, but it's tenuous. Oftentimes, a minimal injury will change that situation completely. So in this context, you've got the patient who presents differently, the clinical findings that are variable, imaging studies which are going to show a massive rotator cuff tear, and you've decided an implant is the best approach, then you have to consider the options. Well, nowadays, the only option really is a reverse shoulder arthroplasty. There is really no role for a proximal humeral replacement, even with a modified head, because they just don't work. I would say the only role this could have would be for a failed reverse shoulder replacement. And as I mentioned before, they don't work because it doesn't resolve anterior superior escape, doesn't improve range of motion, and the pain improvement is modest at best. And I want to say a word about the extended head, or the so-called cuff tear arthropathy humeral component. This is not used near as extensively, but some people still advocate it. I think that this was a nice idea in principle, but I've not seen any reports in the literature that really justify its use as making a difference versus a hemiarthroplasty. So reverse shoulder arthroplasty has become the treatment of choice for patients with massive rotator cuff tears that are not reparable, and fulfill the categories clearly when they're pseudoparalytic, but also in the other category. So let's look at this patient, a 67-year-old with a massive cuff tear, no arthritis, right? Clearly no deformity. That's in my particular case, a reverse shoulder arthroplasty indicated here will give satisfactory results. But look at patient A versus patient B. What are the different outcomes when you can consider the pseudoparalytic versus the patient with a much more functional range of motion? Well, when you consider that, you really have to consider it somewhat historically. The early reports, now keep in mind, these reports from 2009 probably represent patients that were cared for in 2005, which were relatively in the early stages of reverse shoulder arthroplasty, when the overall results of reverses were not near as successful as they are today. This report by Boileau clearly showed that 27% of patients who had a good active forward elevation preoperatively were disappointed or dissatisfied. And these are good surgeons that perform this operation. There's no doubt about it. So their message was, beware of patient B, basically. What I described to you as patient B, they thought was an at-risk group for a unsuccessful result. A year later, Mark Frankel comes out with his report on a similar series, once again complicated by patients who had preoperative forward elevation greater than 90 degrees, had a higher rate of complications, including base plate failure. But again, this was in the early phases of the Frankel prosthesis before they solved base plate fixation issues. If you go a little further along, in 2013, Christian Gerber, now keep in mind, these are well-known shoulder surgeons, so the quality of the surgery is really not in question. He reported a 37% complication rate and a 50% failure rate in patients who had reverse for rotator cuff tears in patients younger than the age of 65. Not quite completely patient B, but certainly in that category. 2015, another report by Frankel, a little better, but clearly now emphasized that the better preoperative function at age less than 60 years were the risk factors for poor functional outcomes. So, however, right, I think things have changed with reverses, just as the results have now arrived on anatomics. This is a report that we came out with in 2021. This is a multi-institutional database that we've maintained for the Equinox shoulder system. Many surgeons, many institutions, 200 patients. We divided patients into 4 groups. Those with preoperative active forward elevation less than 60, between 60 and 90, between 90 and 120, and greater than 120 degrees. All groups improved. The best satisfaction, the highest satisfaction, was in the patients who had preoperative forward elevation of 120 degrees. That was surprising and frankly was contrary to all the other reports. The complication rates were low and the revision rates were quite low. I think this represents not anything unique to the implant, not anything unique to patient selection, but I think it represents the benefit of 15 to 20 years of improvement in the reverse shoulder arthroplasty, and how we much better understand the operation and the indication now than we did in those earlier reports. So my specific approach is, for me, the reverse shoulder arthroplasty is the procedure of choice. But if I have somebody that I think has a reparable rotator cuff tear, where I'm not sure, I send them to one of my colleagues who you listened to prior to myself, and I get their opinion, since I'm not repairing rotator cuffs anymore. However, for me, patient A, it's easy, reverses. Patient B is a little more complicated. They really have to understand that there's a risk they may have less range of motion postoperatively, but you're doing this to relieve pain. And in that context, I take certain approaches from a technique perspective. They will have some intact rotator cuff tissue, and that's important, particularly the most posterior portion of the cuff. If they have a subscapularis intact or reasonably intact, I will try and do this. You can try to spare the subscapularis. I do make a careful assessment of intraoperative range of motion, because you can't make these patients too tight. If you make them too tight, they'll have even greater problems regaining preoperative range of motion. So avoiding excessive tensioning, particularly in patient type B, is critically important. So in summary, right, this is a challenging population, but not near as challenging as it used to be when we didn't have the reverse shoulder arthroplasty available. When the patients come into my office, I'd much rather see patient A than patient B, but I'm no longer that concerned about the outcomes of patient B. The early results of complications, I think we've resolved a lot of that most shoulder arthroplasty specialists will tell you. The patient B preoperative discussion is essential because they need to know that it's a little different than if they were pseudoparalytic. And postoperative management activity level is important because in these patients that are younger, we still don't have the 20-year follow-up of reverses. And a higher activity level, we really need to be careful in these patients because a mechanical failure of the reverse shoulder arthroplasty, right, may really truly leave you in a salvage situation. So I always caution these patients about their activity level following this procedure. So with that, I'll stop and turn it back over to our moderator, Dr. Burke.
Thank you, Dr. Zuckerman. That was a great talk. As you guys can all, as everyone can see, we went through a series of talks in which we described multiple treatment options that are available for massive rotator cuff tears or failed rotator cuff tears, and how these options may be specific to certain situations. I have a few cases that we're going to go through in an attempt to utilize the principles that we just discussed and try to make it more of a real world scenario. So I will be presenting a case, and then we'll have each of the speakers weigh in, and we'll have a discussion that gives us maximum information regarding our approach. So the first patient is a 36-year-old male, right-handed dominant, with a right shoulder, who presented to my office with right shoulder pain and weakness. He reports a history of car accident 1 year prior to seeing me.
Dr. Burke? Dr. Burke? Absolutely reverse. Okay, next case. Next case. All right.
I am going to definitely pitch it to you, Dr. Zuckerman, at the end, and I would love to know why it is so simple for a reverse. So this gentleman stated that he sustained a shoulder dislocation and a rotator cuff tear. He subsequently had 2 arthroscopic surgeries. He was not sure about the first one, where he was told that repair could not be performed. The second one had a repair done. Going through his second operative note, there was no subscap repair done, just as additional information to the rest of the panel. He's a non-smoker, reasonable guy, BMI of 38, has past medical history of depression, for which he takes antidepressants, and hypertension at this age. Past surgical history, as I mentioned. His exam significant for old heel scars from his prior surgery. His range of motion was active forward elevation to 70. He can hold it there. He does not have a drop arm at that. But if you elevate him passively, he has near full motion, but cannot really hold his arm up there. His external rotation is to 30, internal rotation to L5. His rotator cuff strength is 4 out of 5 in all 3 planes. This is his x-ray in my office, and basically shows his post-surgical, implant and mild anterior subluxation. And I'm going to review the other images before we go on for the discussion, just for clarity purposes for everybody. The next slide is series of MRIs, which I was able to obtain. This is prior to his surgery, which means this was his post-injury imaging, and this is the MRI. Dr. Rotator, can you walk us through as to what you see on these, which are basically an axial images, a coronal T2, and then far right, the sagittal T1. At the bottom panel, I have coronal T2 at the anterior part of the supra, coronal T2 at posterior, and then a sagittal.
So the axial cut, the top left, on my view, looks like there's subscap is torn. I think that's probably his biceps there that's medially dislocated. Going down, you can see the proximal humeral migration. I don't really see any tendon tissue on top of the head, so the acromiohumeral interval is really negligent. I see decent muscle though on the sagittal images, specifically the one on the right. I'm not sure what that middle view is here. That looks kind of fuzzy, but overall decent muscle. No subscap, no supra. Not
Possibly
sure.
some infra, the middle panel.
A little bit of infra, right? Yeah, see that.
So this was his MRI prior to any kind of intervention. I guess this was his post-dislocation MRI. And then this was his MRI after the second surgery in the next panel. And Dr. Kwan, do you see any significant changes after this second MRI after the surgery?
So let's see, subscap still not on. I don't know what the third view is. Lots of anchors, at least 5 anchors. Let's see, I gotta move the window here. So subscap's not on. The teres minor may be on. Can't tell, but certainly supra is off. Now you're seeing muscle atrophy. Upper subscap is obviously atrophy. Supra is atrophied. That's sort of it. It has so not much arthritis, not yet, but like I said, he's defective in the anterior cuff for sure. So he's now starting to sublux a little bit as well.
So now this is a change that happened within 9 months. So 3 months.
So this is change with 9 months and 1 surgery or 2 surgeries?
So the first one, I'm not sure if it was just a bicep tenotomy, debridement. I didn't have access to that operative note. And then 2 months after that, there was a second surgery, which was basically a repair, which is what this MRI post-repair is.
Yeah, we're heading towards reverse, I think.
Not yet. Let's see.
I was only kidding.
So like Dr. Rotator and Dr. Kwan pointed out, young male presently has a full thickness upper half of subscap tear, full thickness complete supraspinatus tear, full thickness upper 2/3 of the infraspinatus tear. More than grade 2 fatty atrophy in supraspinatus and infraspinatus, and he has mild glenohumeral OA based on his x-ray that I showed. Dr. Jazravi, this patient is now in your office. Can you walk us what your treatment approach would be for this guy unless you are going to just put a spacer in him?
Okay, so the one thing I would do is a lidocaine challenge test. You inject a subacromial space to see he's only got 70 degrees of forward elevation. I want to see if that's a pain thing or if he can get his arm above head, because that will sort of guide me. I know we've been jokingly talking about the reverse, but if he can't get his arm above his head, it's certainly up there as an option. So I would do that and get a sense of that. In terms of the options here, if he had a functional shoulder, meaning he had a little more motion, maybe that's where you can start considering the SCR in a case like this. I think he's young for a balloon. Essentially, you want to get, something, in there. The balloon will go away and he'll be back still with a massive tear. The subscap concerns me as well. My initial gut was that if they got the subscap to heal, then we could do a lower trap transfer on him as a young guy to get some, function back. So the question of doing an anterior transfer and a posterior transfer on him is an option, but it is, morbid. I think if he doesn't have that ability to get his arm, above his head, so if the lidocaine challenge fails and he's sort of pseudo-paralytic, I would be concerned about an SCR. The only thing that would lean me towards that as the next procedure is that he has good muscle. So his Goutallier is essentially 1. And so with that there, with muscle there, that's where the SCR could win and get this guy, his arm to be raised above head. But you need to be able to fix that subscap.
Dr. Kwan, does BMI, smoking status, walk into your strategy for determining tendon transfer versus doing something less aggressive in a candidate like him?
Not for tendon transfers. I will moan about it because they just made the surgery a little more difficult, especially with the latissimus. That's a lot of fat and muscle you got to go through. But as to my knowledge, there's been no data that suggests inferior clinical outcomes. It may be, but certainly there's no clinical data to suggest that. There's definitely some data suggesting that rotator cuff repair, they don't do as well if with those risk factors, but nothing for tendon transfers.
Dr. Rotator, quick question. When you counsel these patients for any surgical treatment that you're going to offer them, so how do you kind of, what's your approach in terms of what kind of numbers? For example, this guy, he walks into your office. Let's say you made a plan that, hey, I got to do something for this guy. He needs it. For this kind of a patient, what kind of range of motion numbers, what kind of pain relief would you throw in order to, counsel him for a surgical treatment that you're planning?
Well, I don't think I have specific numbers, but I agree with what's been said. I think with regards to what Dr. Jazrawi said, I think doing a lidocaine challenge test is an important part of the decision-making to see whether or not it's true weakness or whether or not it's pain-related. And then going back to what Dr. Zuckerman said, see whether or not this patient is more of a patient A or a patient B. I think once you decide that they're closer to a patient who needs fits the arthroplasty criterion, then they're going to an arthroplasty surgeon, and everything else becomes what can be done for this young patient. And I think the age here is the most challenging, because I don't think we'd be having this discussion if this patient was an older patient. I think the big issue here is the patient's age and whether or not it's appropriate to do an arthroplasty in such a young person. So I think you have to categorize the person first, with regards to the criterion that we talked about, and then figure out what the best approach is. Is it a transfer? Is it some type of pain relieving procedure, a SCR, balloon? I think this patient is long gone from the repair category.
Would you offer him a partial repair, Dr. Rotator, or is this a guy beyond that stage for you?
Just looking at this, I think it's beyond that. In a different circumstance where there was perhaps a failed repair times one and better function, you could consider going and revising this to some type of or getting some type of force coupling to improve some function there. But that does not look like the case here.
I'm sorry, to weigh in, I would actually consider doing a partial repair, because let's say, for example, you want to consider other options, whether it be SCR or tendon transfers. That'll kind of depend on if you could at least get repair of one or two of those tendons to make them to be a better candidate for that. I agree with Dr. Rikito that the chance that you could repair all the torn tendon is, minimal to none. But you might be able to get majority of the subscap to heal, and then he may then be able to have either better motion, or even if it doesn't, he may be a better candidate for a transfer or SCR. Or if you get the supra and infra to heal, then you could do a tendon transfer from the front. So meaning, at least even if you can't get all three of the torn tendons to heal, if you at least get one or two of those to heal, it kind of changes how shoulder is going to work. And even if he needs another surgery, he may be a better candidate for some of those.
I think one teaching point, and I'll just point this out, and I'm not sure it's easy to be a Monday morning quarterback, but if you look back, this is an odd case, right? It's a young patient, dislocated their shoulder, under 40. You don't expect this kind of a rotator cuff tear in this person. Having said that, you question whether or not there was some type of subscap compromise which was missed. And I think the teaching point here is potentially, not to be critical, was there a subscap tear initially or an anterior superior tear that could have been addressed that was missed, and this is what it went on to.
That's a great point. Considering your excitement, Dr. Zuckerman, for reverse, when would this person qualify for a reverse in your hands? When would you do a reverse on this guy?
Well, I would do it as soon as my colleagues tell me that they can't do anything else, right? And it sounds like that there's you guys are trying to figure out what you can possibly do in this guy. He's 36 years old. He doesn't have any. He's only increasing to 70. I'd be shocked if the lidocaine injection made a significant difference. In the 8 months between the first MRI and the second MRI, he's got much more atrophy involved with the subscapularis and the supraspinatus. I mean, he's going completely the wrong direction. Now, and I'm not sure that an extensive operation in this guy, partial repairs with or without tendon transfers, is going to be successful, because he's shown something strange already, right? As Dr. Ricchito pointed out, 36-year-olds who dislocate their shoulder don't have rotator cuff tears like this usually. So I think he's got a bit of a tissue problem, and I'm sorry I can't be more specific than that. But all the things that you guys have suggested, if you don't think they're going to be successful, then I would certainly do reverse. But my problem with all the other, this is a little bit like, what we used to talk about, patients with, severe trauma to the lower extremity, to a leg, to the tibia fibula, when they had non-unions and they had tissue transfer procedures, this and that. And ultimately they decided they're better off with an amputation than going through all these reconstructions with nerve injuries and such. Now, I know that's extreme. This guy, I can envision him going through multiple more procedures, and 3 years from now, right, having a reverse, because none of this stuff is going to work, right? And the problem I have with, even though he's 36 or 38 now, and everybody's concerned about a arthroplasty in a 36-year-old, I think it could be the most reliable procedure that we could suggest in this particular situation.
Dr. Zuckerman, does this patient kind of fit into your patient A category?
Well, no, I think, yeah, it's more A than B. Probably I should have said that patient A and patient F, and make this guy like a C, right? Because he's in between.
Would you do anything during the surgery or post-op rehab in a guy that you're already envisioning, like, hey, multiple complications, I'm sure dislocation, intraoperative tensioning of this patient, any role for tendon transfer while you're doing intraoperatively? What would your considerations be in order to minimize any of those complications that are right in front of your face, thinking that this guy is going to have one of them?
Yeah. So I become a non-tendon transfer reverse guy, right? Because I think that they are, it complicates it, and it's a longer run for a little, if any, gain, at least in my limited experience now. And I know that that's an opinion more than anything else. So I'm happy, particularly in younger patients, and he's got some rotator cuff posteriorly, in just doing the reverse and not doing any tendon transfers here.
So like, each one of you pointed out, this is not a straightforward case. Patient has certain characteristics which, put him at a high risk for anything that we do. His original injury, the extent of muscle atrophy and everything. So I had a great deal of discussion with this guy. And, eventually for this gentleman, I opted for a partial repair, because I was pretty convinced, looking at his first MRI and second MRI, that his upper part of subscap is definitely torn. And I was hoping, I gave him a very realistic goal. I said, you're 60 or 70 forward elevation. I'm going to try a procedure which has least morbidity. And if I can get you to 110, 120, that's going to be my goal. Pain relief, again, I'm not sure if I can give you 50%, more than 50% of pain relief. Just made up a number in order to, counsel him, because I myself didn't have that kind of a vision to tell him, like, hey, just a partial repair is going to give you what you need. So during surgery, I did find the subscap tendon that was not repaired. It was all scarred in anteriorly, as shown in this picture third on the upper top panel. He did have mild arthritis. I don't know if these are post-surgical changes, but his joint did not look super healthy. And I was able to repair his subscapularis with 2 anchors. Likewise, I was able to tease out his infraspinatus and posterior-most part of supraspinatus, and I was able to do the posterior cuff repair. And this gentleman is around 2 years out from that surgery, and he has around anywhere between 100 to 110, but surprisingly says, I don't have much pain. So even though his range of motion not improved, and he said, you already told me it's not going to be great, maybe pain relief will be better, he's a satisfied patient, maybe largely because his expectations were set low, and I feel pain is a big driving force in majority of our patients, and I think he felt he's doing good. And that also actually brings us to the end of our webinar. We are 1 minute up. I want to thank all the panelists for their talks as well as their important discussion points. And I want to thank all the participants who took time to participate in our webinar. And thank you, everybody, and good evening.